Good afternoon and welcome to today's IAC webinar, Achieving Quality in Cardiac PET Part 2, Interpretation Best Practices. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ARRT Category A CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce today's guest presenter, Dr. Jameson Bork. Dr. Bork is the Medical Director of Nuclear Cardiology and the Stress Lab at the University of Virginia Health System in Charlottesville, Virginia. Currently, he is an Associate Professor of Medicine and Radiology at University of Virginia. Dr. Bork specializes in advanced cardiovascular imaging, management of coronary artery disease and ischemia, and coronary microvascular disease. He has a clinical and research interest in patient-centered imaging, and we are happy to have him with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Bork. Doctor?
Thank you, Kelly. I appreciate the opportunity to speak today and appreciate all of you logging in and spending time with us. So the title of my talk is Achieving Quality in Cardiac PET Part 2, Interpretation Best Practices Illustrated Through Cases. And we'll go ahead and get started. Here are my disclosures. And so my learning objectives for you today are for you to be able to illustrate the importance of quality images for optimal cardiovascular PET-CT interpretation. I want you to be able to define the components necessary for a complete cardiovascular PET-CT interpretation. And I want you to be able to apply optimal PET-CT interpretation skills in contemporary cases. And so let's get into it. Case number 1, history. Case is an 81-year-old male. He has chronic kidney disease, hypertension, and an extensive prior history of tobacco abuse. He comes into clinic with progressive dyspnea on exertion, as well as progressive lower extremity edema. And on lab testing, he has a mildly elevated BNP of 232, up from a prior baseline known of 72. And his CT of his chest CT from recently, prior to the onset of these symptoms, showed moderate coronary artery calcifications. So he was referred for a PET MPI study, and this is what was seen. So he had vasodilator stress ECG that showed no abnormalities, and then here are the relative perfusion images. And if you look here, you can see that the heart appears dilated. There's not really necessarily any evidence of transient ischemic dilation. And if you look at the perfusion, there doesn't appear to be any focal areas of perfusion abnormality. And if you look down at the polar plots, when these images were compared to a database of normals, you can see that there are no areas that were flagged as abnormal. So the relative perfusion on this imaging appears to be normal. So the gated imaging was, of course, performed as part of a comprehensive PET evaluation. And so this is sort of one thing to note is it's extremely important to do your gated imaging and derive function, as it can provide a lot of very useful information. And as you can see here, the gated function is mildly reduced and appears to be in a global pattern. And so we next looked at the absolute flow. So one of the advantages to PET, in addition to our ability to look at relative perfusion and gated function, we can also look at absolute flow. Given that the ring detector is all the way around the patient and is constantly gathering information, you can literally watch the counts come into the right ventricle, into the left ventricle, and then into the tissue. And using mathematical equations, you can calculate the absolute flow in mil per gram per minute. And you can see here, if you look over to the right and we look at our stress flow, right here, you can see that the stress flow is reduced. Normal would be 2 or greater, and so these are reduced. But more striking than that is that the rest flow appears to be essentially the same as the stress flow. And so our myocardial flow reserve, which is the augmentation from rest to stress, which is an important marker of either epicardial disease or microvascular function, appears to be 1. There's no increase from rest to stress. And so the question is whether that is something that is of clinical significance or not. And so the concern was, in looking at that the patient might have had failure of the stress agent to actually dilate the blood vessels. And therefore, we wouldn't see an increase in flow because essentially the patient remained at rest. And so the first step was to immediately ask the patient very nicely several times whether they had had any caffeine. And even the different types of caffeine were specifically asked, because that would be by far and away the most common reason that a vasodilator would fail. It's also possible that the patient could have a failure of that vasodilator for other reasons. And so the cleanest way to proceed in this situation, if the patient says, well, yes, I did. I had a Starbucks Venti, some sort of caffeinated drink, then you would just have the patient come in and repeat the stress portion. However, even if they don't report caffeine, it would probably make sense to have this patient come back and have repeat imaging with a new stress agent, such as dobutamine. However, this patient had very prominent symptoms, and given the newly reduced ejection fraction and the fact that they had the prominent symptoms, the referring provider elected to pursue catheterization rather than do additional imaging. So in conclusion, patient prep is key for adequate stress, and inquiry about caffeine is essential. A myocardial flow reserve of approximately 1.0 suggests failure of the stress agent, but should be correlated clinically. And repeat stress with a different agent is the best next step. That patient, this was a fairly recent case, so that patient has not had their angiography yet. It really wouldn't surprise me if it went either way here. This patient may very well have significant coronary disease, but I suspect that the reason that we didn't see any increase in flow reserve was due to failure of the stress agent. So it's very important when you're dealing with cardiac PET to obtain and interpret quality data. So you need to make sure that the stressor has indeed done what it's supposed to do. And then misregistration is an additional aspect that we have to worry about, in particular with PET and PET CT, where you have to look at the fusion of the PET image with the CT image. And here's a nice example where if you see sort of appropriate registration here, and then you can see where they artificially have misregistered you can see the sort of dark line here where the PET image is hanging out over the lung field, and it's even more prominent here. And you can see that also here in the coronal view. And what that results in when you look at the perfusion images is a prominent anterolateral perfusion defect that is not at all due to abnormal perfusion. It's due to misregistration. Patient motion can certainly provide artifacts that have similar issues, and then gating artifacts can result in an abnormal function assessment, and often that happens in the setting of frequent ventricular ectopy or atrial fibrillation, where the computer is unable to properly gate the images, and thus counts are sort of not put where they belong, and so you get something that looks like it's reduced function when in reality the function was normal. So moving on, case number 2 is a 73-year-old male who has exertional dyspnea and a prior bad experience with angioplasty and would prefer medical therapy. He had a stress test in 2002 that showed a mild inferior fixed defect, and at that time a catheterization showed a chronic total occlusion of the right coronary artery, and he was treated medically with very good response for a long period of time. However, he now comes back in with exertional dyspnea, and further stress testing was warranted. So he undergoes cardiac PET CT, and you can see here that the perfusion is abnormal. There is what looks to be an apical, but especially mid to basal inferior and infralateral perfusion defect that appears to be predominantly fixed if you look at the images more basilar. But as we come more mid, we can see that there starts to be more reversibility. And so this defect was thought to have at least partial reversibility and therefore be consistent with ischemia and infarction. We could potentially say the patient had peri-infarct ischemia, but I think that the amount of ischemia here is a little more than that. I try to reserve peri-infarct ischemia for when I'm talking about just a little bit of ischemia nipping at the edges of an infarct. And this really seems to me to have sort of two distinct components to it. You can also see that the cavity is dilated, similar to our last patient. And in contrast to the first patient, the cavity appears to be more dilated at stress here than at rest. And so there was at least visual concern of some transient ischemic dilation. And when we look at the function, we can see that the function is markedly reduced. Ejection fraction is in the 22 to 26% range. You can see that it's down everywhere, although there appears to be, in particular, a decrease in the region where we were seeing the perfusion abnormality. And so here the gated function has nicely confirmed what we're seeing on our relative perfusion images. And so the question is, are there other tools from this cardiac PET exam that could aid in our diagnosis? And so we've already seen at least one tool that can be of additional assistance, which is the absolute flow. And we'll look at that in a second for this patient. But the other very valuable piece of information we get when we do cardiac PET CT is the ability to assess coronary calcification. And so we look at our CT attenuation scans, and you can see here that there is calcification in the left main, calcification in the LAD territory here, calcification in the RCA, and I haven't shown it particularly well here, but the patient has calcification in the left circumflex artery as well. And so this is additional information that can be of use. There are protocols that allow you to actually use an attenuation scan and develop a full sort of diagnostic calcium score, an Agatston score off of those images. Or at the very least, you can make assessments of the qualitative degree of presence and absence, at the very least, of coronary calcification. So here is the absolute flow for this patient. And what you can see is that if we look in the bottom left here, the absolute flow is markedly reduced at stress, similar to our last patient, but in this situation, the rest flow is even lower. So you can see that the flow reserve suggests that there is, this is abnormal, but there was some augmentation of flow, which suggests that indeed there was an adequate stress response. You can see here that the RCA flow is the lowest and is reduced at rest as well, and that would go along with the fact that we were looking at an infarct in that inferior territory. And so all of these together, so when you looked at the initial images, we saw what looked like a fairly isolated defect to the inferior infralateral wall. But after you add the 3-vessel coronary calcifications and 3-vessel reduced absolute flow, not to mention gated function that is severely reduced, all of these things would suggest that indeed this patient probably has more extensive disease than what we were seeing on that initial relative perfusion study. And sure enough, when we do coronary angiography, you can see that the right coronary artery remains occluded. This was known previously. And then on the left side, you can see that we don't get a good look at, it looks like the left circumflex is occluded as well. And there's significant obstruction in the LAD territory. And you can see there's some collaterals here back to the right side. So in conclusion, the patient underwent CABG with improvement in symptoms, and a recovery of function was planned on a repeat echo. So in conclusion, relative perfusion images can underestimate the extent and severity of disease. And so in this situation, I think even had we not had absolute flow in the coronary calcifications, the reduced left ventricular function and transient ischemic dilation would have given us a pretty good clue that something was going on here. But certainly having the coronary calcium on CT and the absolute flow provide very valuable additional pieces of information to help differentiate an ischemic versus non-ischemic etiology of reduced LV function and the extent of disease, a number of diseased vessels affected. So I just wanted to bring up a couple of additional thoughts that I had in terms of what you might provide in an interpretation of cardiac PET. So these are sort of what our reporting software looks like. We actually worked with Epic to sort of develop a system at UVA, and so we have the size and the extent and the area that's affected, the severity, and importantly, so we provide for each defect those terms, but we also, for each defect that we've arranged by which one, what vessels we think are affected, we also provide an individual conclusion for each perfusion defect. So you can see here that if we said it was a severe and reversible defect, that we're going to call it ischemia. If we had said it was entirely fixed, we would have called it infarction. If we said that it was reversible, well, let's say we said it was fixed, but we had called it a probably normal scan, we would have then said that this was probable artifact versus infarct. And so we have the ability to provide those sort of perfusion defect specific conclusions. And this can be done with multiple different software programs, but I think it's important that you provide that specific information. And so down here in the comments, you can see perfusion comments, LV perfusion is abnormal, and then it describes that defect. And the defect appears to be ischemia. So I think that's one important component when you're doing your reporting. The other aspect that's important to this is that when you have absolute flow information, you have to both provide what you think is going on in the relative perfusion, but also reconcile that with what you're seeing in the absolute flow. And so we will typically provide some sort of comment on whether the absolute flow confirms that defect or whether we thought it was artifactual afterwards. So another important component is to consider having polar plots in your report. And these polar plots are not the ones that are generated by the computer software, which I think often have artifacts in them, but these are actually generated by our readers. And as you can see, this is what the reader felt truth was. So there was a perfusion defect in the infralateral wall, and then there was a more prominent defect. I'm sorry, I wanted to show polar plots, and this does not actually correspond to the case we were just looking at. I was looking over at the left, and I said, wow, there was a lot more perfusion defect than I thought. But the point is that when you are looking at a report, you can have the ability, let's say you're a busy provider and you've gotten this report, you can very quickly see that this patient is severely abnormal and you need to pay a fair amount of time looking at this at this report. So I think it provides really helpful visual analysis. It's also helpful for you, the interpreter, when you are looking at to generate the polar plots and then have the polar plots to the side as you're generating the text that you want to say. I think it allows you to be very consistent and with your reporting. So other elements that should be included, don't ignore the stress electrocardiogram. There are things like the hemodynamics that are provided with that, as well as any ECG changes that are very important in the interpretation of the study. Patients who have normal perfusion imaging but have a blood pressure that skyrockets into the 200s during stress may just have uncontrolled hypertension as the cause of their symptoms. So other pieces of information to include, such as the some stress score, some rest score, some difference score, and percent LV ischemia can be provided. One question is whether you should report coronary territory. So we tend to shy away from doing that, except in a couple of specific instances. One being if you actually have a recent catheterization, and so you know what defects the patient has, and you're assigning ischemic territories to those known defects. Potentially, you could even do this if somebody had had a catheterization previously, and you at least knew whether they had a large OM that tended to cover a certain area, for instance. But the only other time I will do it is when someone has a very classic LAD distribution. Then I'll tend to call that. But I think you get into trouble if you start waxing poetic on inferior versus infralateral defects and whether they represent RCA versus OM lesions and such. It's also really important to compare to prior studies. In addition to the other components that I talked about that were specific to cardiac PET, such as our ability to look at absolute flow and coronary calcification, there is additional value in the fact that we typically get both a resting and a true stress left ventricular ejection fraction. So the patient is under the camera and getting imaged as the vasodilator is going in, and such. We would consider that a peak stress ejection fraction. And so it turns out that Sharmila Durvala et al. At the Brigham have looked at the change in left ventricular ejection fraction, or the difference between rest and stress, and have shown that patients who have 2-vessel or 3-vessel coronary disease typically have a drop in their ejection fraction, or it at least stays the same, it doesn't go up, whereas people who have 1-vessel disease or no obstructive coronary disease typically have a several percentage point increase in their ejection fraction from rest to stress. Okay. So those are some sort of aspects to consider reporting when you're interpreting your study. let's talk about some other components that are important. So case number 3 is a 55-year-old female. She has a history of hypertension, diet-controlled diabetes, and a 10-pack year history. She has a history of an unprovoked pulmonary embolism. And she comes in with some mild, long-standing dyspnea on exertion, but really this was not what brought her in. It was mainly that she needs pre-op resection of a pancreatic adenocarcinoma, and they wanted to get further risk stratify her. Challenging this entire case is the fact that she has morbid obesity with a BMI of 56. So here are her PET MPI images. She had a normal vasodilator stress electrocardiogram, and here are her images. And if you look at these images, you can see that there is the presence of a septal and possibly, or septal, anoroseptal, infraseptal kind of perfusion defect that goes at least into the mid-wall, with maybe a little bit of anterior involvement, but predominantly septal. And you can see that both at the here on the short axis images, but you can also see it when you look at the horizontal and vertical long axes. And so this is something that we would want to evaluate more carefully. I will tell you from experience of dealing with doing imaging on a lot of obese patients, that this sort of defect is one that we may end up seeing be artifactual. But I think without additional tools, it would be very difficult to just completely dismiss this perfusion abnormality that we're seeing on the relative images. So we get additional information. So with the gated function, we can see that the function is fairly good and is globally intact. There are no focal segmental wall motion abnormalities where we saw our concerning defect in the septum. And then we can look at our CT attenuation scan if you have one available. And what you can see in the single shot, but also through a full review of the entire CT, is that there was no coronary calcium appreciated. And so certainly that would that's a step in the right direction. Now, as I know you all know, someone who's having symptoms and has a defect in any particular territory, just because you don't see coronary calcium there does not definitively rule out the fact that they may have obstructive coronary disease. As a fairly robust subset of the population, when they have a single abnormality, can have obstruction despite not having any coronary calcification. But what really bails us out in this case is the patient had absolute flow performed. And what you can see when you look over here at the stress flow is the stress flow is very robust. It's greater than 3 in all territories and globally. And the rest flow is normal. And so the flow reserve is very robust as well. So anything over 2.4, 2.5 would be considered normal. And here we're well into the 3s and above. So this absolute flow combined with a negative coronary calcium, normal stress function, and the concerning defect we saw in the relative perfusion, we would say that that defect is very likely artifact, and we would read this as a normal study. You might, decide based on if they had a more concerning story that you might call it probably normal. But in this case, given that she didn't have any new symptoms, we felt this was normal, and we read it as such. So for this patient, the follow-up was she underwent surgery, her adenocarcinoma surgery, without cardiovascular complication. She has had no increase in symptoms subsequent and is increasing her physical activity to improve her conditioning and stimulate weight loss. The thought was that her mild dyspnea on exertion was likely due to deconditioning in her weight rather than a cardiovascular etiology. So in conclusion, despite increased count sensitivity, severe obesity results in frequent relative perfusion abnormalities that have to be sorted out. So fortunately, CT coronary calcium and gated function can provide added information, but in particular, absolute flow quantification can help characterize relative perfusion abnormalities as artifact and limit our need to perform subsequent invasive or other testing. And it's important to remember that the presenting symptoms or lack thereof remain key components in the interpretation of your study. So here you can see coronary calcification, and we've got no coronary calcium on the left. In the middle, we've got mild to moderate calcification, and on the right, severe calcification, where you can see the entire vessel affected. It's worth noting that when we're dealing with hybrid imaging, and in this case, we might not call it classic hybrid imaging in that we're not getting a full cardiac CT, but certainly the coronary calcium provides added information. So we take our clinical risk and we add our ischemic burden by the PET, and that helps tell us the need for revascularization. We then add our CT coronary calcium information in, and that helps us with anatomic burden and overall disease activity, and that helps us know what our goals are and what goal levels and intensity of medical therapy is necessary. Case number 4 is a 39-year-old female. She has a history of coronary artery disease and had prior PCI to her LAD. She has hypertension, dyslipidemia, and elevated fasting glucose. Very unfortunate case in how young she was. And unfortunately, this is complicated by the fact that she has a history of severe anxiety. So she comes in with progressive exertional chest and throat discomfort, but she also has an atypical resting chest pain. And so the question was whether there was, whether all of these symptoms were due to her anxiety or whether she indeed had progression of her coronary disease. So she was currently taking dual antiplatelet therapy, high-intensity statin, beta blocker, and amlodipine. And here is her resting ECG. You can see that there are no abnormalities here, relatively normal resting ECG. And then here is her post-vasodilator ECG. So we gave the vasodilator, and then we looked at her ECG. And you can see that there is ST depression notable in 1, 2, AVF, maybe a tiny bit in AVL, and then certainly in the lateral leads here, V4 through V6. And the ST depression is at least 1 millimeter or greater, almost 2 in some of the leads. And so this was thought to be concerning. There is some debate about what the specificity of a vasodilator ECG is, but I think the majority of data and current expert opinion is that a vasodilator ECG that's positive is concerning for coronary disease, and further evaluation should be considered. So this was certainly something to keep in the back of our mind. We then look at her PET images, and what you can see here is that the relative perfusion looks relatively normal, and the computer is flagging some sort of basal septal stuff, but that's really where valve plane is, and so we wouldn't be terribly concerned about that area. And otherwise, the database was normal. So gated gated PET was performed, and you can see that the function is good, and there are no focal abnormalities to suggest a perfusion defect. So this really gets to an issue, which is we've now got a relatively normal looking PET study, but we have this abnormal ECG. And this brings up a very important point that the IAC has hammered home, and that is the importance of having a combined conclusion that incorporates both your stress electrocardiogram and your stress imaging. I would like to point out really quickly that when we look at the vasodilator ECG, that if it's normal, that doesn't necessarily help us a lot, because we know that vasodilator stress electrocardiography is not particularly sensitive. So it helps us if it's positive. It doesn't help us so much if it's negative. So this brings up sort of challenges in combined conclusion, and that is what to do. So it's easy if you've got concordant negative or positive, or even if the SPECT is, or imaging, perfusion imaging is positive, but your ECG is negative, then we would just go with kind of what the function was showing. However, what do you do when you have negative imaging and a positive stress electrocardiogram? And the concern is that there is good data showing that the patients in this situation have a higher risk, and that's because some of them have real disease and some don't, and so it's a gradation. And so how can you, as a interpreter and an image or in your report, help provide guidance to the referring clinician on what to do with this information? And so we've actually come up with a way to do this, and in revising the ASNC reporting guidelines a couple of years ago, I brought sort of what we do at UVA up, and it's actually been incorporated into the guidelines. So hopefully you find it useful, or at least can adapt it to something that works well in your situation. But what I really struggled with was the concept that often we have not actually spoken to the patient. So how do we sort of make a judgment without seeing the patient? And then how do we communicate that to our provider? And so we want to come up with a clinical risk and provide a recommendation. And so what we ended up doing is saying, okay, well, there's some things that we observe during our stress test, or that we know readily from the information collected when they come to the lab. So we certainly know their age and demographics. We know their basic cardiac risk factors. We know what symptoms they presented with, at least on a global scale. This was a really typical angina versus not so typical. And admittedly, some of that is only as good as the information in the note. But so we look at things like their exercise workload, angina on the treadmill, their number of risk factors, and we come up with a gradation of risk. So if we look here for someone who's discordant with an ECG that's positive and imaging that's negative, we then look at our cardiovascular risk. And we may say something like it's low risk because they had atypical clinical presentation, they were young, they had a high exercise workload achieved. And so we'd say this study is low risk and clinical correlation is advised, but in the absence of progressive or typical angina, further cardiac evaluation may not be necessary. In contrast, if they have intermediate risk in you looking at the information that you have available, you could actually say further evaluation could be considered. And an important point to note here is that for each of these, what you clicked on is provided so that you can say, well, I'm making this determination because I think that they were atypical symptoms. And then the referring can look at your statement and say, you know, they weren't right about that. Or maybe I didn't put it in the note, or I was thinking about it later, or I know this patient well, and those symptoms are actually typical. So it empowers the referring clinician to understand why you were making the statement you were making, and also really highlights the fact that discordant results need to be potentially treated seriously. Another good low-risk situation would be if the perfusion abnormalities resolve in the first minute after stress ends. So this patient, unfortunately, indeed did have significant disease. And so you can look here and see that there's fairly prominent disease in the left circumflex. We have an occluded LAD here, and then the RCA was occluded as well. And so this is a classic example of balanced ischemia. The absolute flow data would help us a lot with this patient, but I wanted to just show you that you can get some of this information even without the absolute flow. In this case, it was the stress ECG that really clued us into there being an abnormality. So in follow-up, the patient received drug-eluting stents ×2 to the LAD and circumflex with good result. Her chest pain resolved, and she has entered cardiac rehab. She plans to return to work shortly. So in conclusion, positive vasodilator stress is highly concerning and warrants consideration of additional testing, especially in the appropriate clinical settings, such as typical angina. So typical symptoms, especially if they have known disease, is particularly concerning, especially when they've been on aggressive medical therapy. And it's really essential to provide the combined electrocardiography imaging report. And this is currently mandated by our high IAC standards. So I want to finish with one last case. 67-year-old female who has a past medical history of pulmonary sarcoidosis and diabetes mellitus. She comes in with shortness of breath, paroxysmal nocturnal dyspnea, and orthopnea for 3 weeks, and unfortunately was admitted with paroxysmal ventricular tachycardia. She received a 24-hour high-fat, no-carbohydrate diet, and this diet can be ruined by so much as a Tic Tac. So there are extremely stringent rules on what the patient can eat the day before imaging, and then they have a 12-hour fast, which is nobody's favorite. But the good news is that if you do this very intensive patient prep, you basically eliminate any typical physiologic uptake of glucose by the heart muscle cells. And so the only cells that take up glucose are those that are obligate glucose users, such as neutrophils. So you can see inflammation. And so this particular patient prep for metabolic imaging is to assess for patient inflammation. And it turns out that we can look at metabolic FDG uptake and perfusion patterns in sarcoidosis and determine disease activity. And you can see that if you have somebody who has normal perfusion and no FDG, that's just a normal study. Unfortunately, if they have diffuse FDG uptake and normal function and normal perfusion, then the concern would be that indeed they were sneaking a Snickers bar before their study. So you would want to repeat the prep and repeat the imaging. Then you can have patients who have just an isolated perfusion defect, and that's probably just an old defect that is no longer active. Or you can have active inflammation that hasn't resulted in a scar yet and say focal FDG uptake. And then sort of the most worrisome is when you see something that's combined where they have FDG uptake in an area where you see a perfusion defect. And that's either where they've had old perfusion, now they have reactivation of inflammation in that area, or it could be that they have ongoing severe inflammation that has actually started to lead to scarring. And when you look at survival free of death or ventricular tachycardia, having these abnormal perfusion and FDG is the most concerning. If either of them are abnormal, then it's kind of in the middle. And if they're both normal, then the patient has a relatively good prognosis. It is important to note that the perfusion abnormalities are not specific to sarcoid, and so you have to rule out coronary disease. So here are the FDG N13 ammonia imaging, and you can see that there's a very prominent perfusion defect starting at the apex and moving all the way to the base in the septal and inferior territories. And there is a corresponding FDG uptake in that area, and this is highly concerning for ongoing severe inflammation that's leading to scar deposition versus, as I was saying, perhaps they had had scar there before, had inflammation there before that had resolved and scarred, and now they have new inflammation in the area. But I would tend to think it's probably the former rather than the latter. Another thing that's really nice with this inflammation imaging is that we can actually repeat the scan after the patient has received definitive therapy. And here you can see this is just the FDG, and you can see that all of that uptake is actually blood pool, and the sort of dark area around it is the myocardium. So this patient had complete resolution in their FDG uptake, and so this is someone who has responded well to therapy. So in follow-up, the patient was tapered off of their immunosuppressive therapy without complication. So FDG PET-CT can assess the extent and severity of active inflammation with cardiac sarcoidosis. Patient preparation is key. And so we can also do viability imaging using FDG, but that's a very different patient prep where you actually get them to, you administer glucose and insulin together, try to keep them at a specific blood glucose, and that encourages the myocardium to take up glucose because you're looking for areas that are metabolically active, even if they're not getting perfusion, and that allows you to see viability imaging. But patient preparation is key to determine what aspect of the myocardial metabolism you want to assess. Perfusion imaging is important in these situations to fully characterize risk. And PET is a great way to do that. Occasionally, we don't have room in our schedule for ammonia imaging, and so we'll actually do SPECT perfusion and combine it with the FDG imaging. And FDG PET-CT can assess the response to therapy. So in summary, careful quality control assessment is necessary to ensure good quality data so that you can provide appropriate interpretation. PET, and this can be done with or without CT, provides substantial information beyond relative perfusion, and that information should be used to maximize your diagnostic accuracy and should certainly be reported. And it's essential to provide combined conclusions that synthesize relative and absolute flow and imaging in the stress electrocardiogram to facilitate overall interpretation. And with that, I will end the part of the presentation portion, and I understand we'll have some questions now.
Okay, thank you. At this time, we'll begin the Q&A session. From IAC, I'd like to introduce Maria Costello, IAC Director of Accreditation for Nuclear PET, and she will be assisting us with the Q&A session today. Maria, would you like to start us off?
Sure. Thank you, Kelly, and thank you, Dr. Bork, for a great webinar. We do have a few questions. The first one is, how much motion, X, Y, Z millimeters, can be tolerated before repeat images should be considered?
That's a good question, and I will be honest, I don't have a great answer in terms of specific sort of measurement of motion change, but I think the concern would be that if you look at the perfusion images and you see that there are perfusion defects, especially if they're matched in a particular axis. So, for instance, you'll have both anterior and inferior defects, or both septal and lateral defects, and you see, that there was shaking, then I would probably rescan at that point. And I think it's always better to err on the side of getting the good information, because otherwise it becomes very challenging to know whether a perfusion defect is real or not. I think if there are no perfusion defects, then generally, unless it's really extreme motion, you probably got away with it, and it would probably be fine.
Okay, thank you. The next question, do you provide flow numbers in the report? And if so, do you include the abnormal territory as well?
So that's a great question. So yes, we do, in the vast majority of situations, provide the absolute flow. We will provide it by the coronary territory and globally, and we'll provide an interpretation of what we think that means. So, for instance, there's a group of patients who have normal stress flows but high resting flows, and therefore their myocardial flow reserve is decreased. And so we'll actually make a statement that this is sort of high resting flow, reduced flow reserve, and that while the sort of prognostic and diagnostic significance of this is not fully known, that it's definitely a patient in whom you would consider microvascular dysfunction, for instance. So we'll try to provide an interpretation. There are some patients in whom it's not as helpful. So someone who has severely reduced LV function, that can be a challenging situation, or somebody who's had prior bypass surgery. And so in those situations, I'll either not provide the absolute flow, or I'll provide it but give a a sort of proviso on the fact that it may be challenged by sort of those complicating factors.
Okay. Do you recommend doing ECG during the rest image?
So we don't typically do the ECG during the resting imaging. So, we definitely get a resting ECG before we start, but that's typically done after the rest imaging before we, once we put them under the camera, we get a rest image before we do the vasodilator.
Okay. Is there an EF percentage difference amount that is reportable when the rest is better than the stress to show abnormality? And does it matter if both are high normal, for example, 75 and 85%?
So that's a good question. I think when you're up that high, I'm not sure that I would really be worried that you're talking about global ischemia. I do think that if it's in the normal range and it goes down a couple of points, but it's still in the normal range, that still could potentially be concerning, especially in the appropriate clinical situation. I will be honest with you. So a lot of that data was done using rubidium. And in our lab, we have not seen that as robust an association as what has been published. And so it's made us a little bit more careful about sort of using that in isolation, but I think that it's additional helpful information. If other things are heading in a certain direction, in a higher risk direction, and you see a several percentage point drop, I think that would sort of add to my concern that something was going on.
Okay, and we have one more question. How do you troubleshoot an abnormal time activity curve on myocardial blood flow, absolute flow? In some patients, the stress curve goes up, not down, like at rest.
So I think hopefully I answer your question helpfully. So we definitely look at the curves. So if you look at the curve here, what we'll see is that what you should see is a very sort of robust peak as you go, as the blood flow goes into the RV, and the same thing in the LV, and then you'll see a small or much smaller increase that then remains steady in the tissue. If you see a stress curve, an LV curve that is sort of goes up and then just sort of zigzags back and forth all the way across the screen, that is not a good test, and I would be very careful about including that data. So I think that there are definitely things that you can do in looking at those curves to make sure you have good data. And I think we would all agree that sort of in the current situation where we've been providing relative imaging without absolute flow for a long, long time, that if you have any question about whether the absolute flow data is accurate, I would not include it. And I would just include a statement that says absolute flow numbers appeared artifactually, to be artifactual and they're not reported, and be done with it.
Thanks again, Maria. Thanks again, everyone. And a very special thank you to Dr. Bork for his presentation today. Please feel free to contact IAC with any questions that were not answered during your Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Achieving Quality in Cardiac PET Part 2, Interpretation Best Practices. Beneath this title, you will click Review Event. Then click the blue Evaluation tab and click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE Transcripts section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.